And we kick off today's program with a very important subject that touches every family, every community, every society, and of course, the nation at large. And that's motherhood, bearing children, and, you know, the pros and cons of that. Curbing maternal and newborn deaths, which is, you know, a very, very important thing to look at. So the Lagos State government is partnering with the Federal Ministry of Health and has launched the Maternal and Neonatal Mortality Reduction Innovation Initiative to drastically reduce preventable maternal and newborn deaths through stronger coordination, smarter use of data, and inclusive health reforms. The Maternal and Neonatal Mortality Reduction Innovation Initiative, called MAMI, which kicked off in Lagos State, is supported by the World Health Organization and other agencies. Now, it's a part of Nigeria's National Health Sector Renewal Investment Initiative, NESRI, which targets a 30% reduction in maternal deaths and a 60% increase in health facility use by the year 2030. That's about how many years from now? That's just about 5 years from now. So we have in the studios with us this morning to talk about this, the Dr. Dayo Adeyanju is to my this side. My sense of direction.
We understand.
to my left. And he's the national team lead of the Maternal and Neonatal Mortality Reduction Innovation Initiative. That's the MAMI I just spoke about. Thank you so much for joining us on the program today.
Pleasure to be here.
And to my right, I have Dr. Oyeyemi Ogunjobi, who's the Swap Desk Officer, Lagos State Ministry of Health.
Good morning.
Thank you so much for joining us again.
Good morning. Thank
today.
you for having me. Thank you.
Right. I know that there was a... Let me start ladies first, you know. Yes, because, you know, there was a time that, you know, when we were talking about deaths of newborns per 100,000, I think, in Nigeria, it was, you know, really skyrocketing. And Nigeria was tragically one of those countries that recorded the highest rates of, you know, infant mortalities, you know, after birth. Where are we? Let's start with that. Where are we now before we start talking about, you know, what we're doing to reduce? You know, I know some of those things might have worked. I don't know, you will tell us more. But where are we at this point, you know, from what we were, like, say, 10 years ago?
Oh, okay. Good morning. Thank you for having me again. I will say that we're taking small steps to reduce the neonatal mortality rate and the maternal mortality rate, but there's a lot still to be done, hence the need for the sector-wide approach, you know, because we've been doing things in silos, every agency trying to curb it in their own way. But the sector-wide approach now is saying, can we all come together? Can we have a more effective way of doing things? The funds, the processes, the activities, everybody should just align so that then we'll see the drastic changes that we expect to see. Yeah.
Maybe I should ask this. From your experience as a woman and as a medical practitioner, what are the causes?
Oh, there's a lot. There's a lot. You know, during the workshop, we actually saw this video clip of, you know, Mami is talking about why did Mrs. X die. You know, if you ask the people out there, why do we think mothers are dying, children are dying, they mostly say it's the health sector. But when you really look at it, it starts from the home. The girl child, the mother, it's actually... You know, they're kind of relegated, and, you know, their health, even to carry pregnancy to full term, your health has to be optimal. You know, the distance of the health facilities, the road networks. And, you know, so we've come to realize that there's a mirage of causes of why mothers die and why babies die. And so I'm thinking that that's why the MAMI initiative was set up to address, because it's sectoral, so it's not only the health sector. We're talking to the NURTW, the blood transfusion, the road networks. You know, there's just so much. The transportation, emergency transportation system. So we're all coming together, and that was what our implementation plan is about. Everybody, the market women, the clergies, the imams, everybody, you know, we're all in the room to come up with the plans, because there were so many factors that played out in the course of maternal mortality.
You know, Dr. Adeyanju, the reason I'm asking that question is so that people can understand where we're coming from and really know, okay, because if we don't know where we are coming from, if we don't know where we are going, at least we know where we are coming from. So if we have an idea of where we are coming from, we might know how to retrace our steps. And then, because the problem is never of fantastic initiatives. Yeah. It's of ownership, exactly. Of sustainability of the people. So in your opinion, and from what you know as a practitioner, what is the reason for these terrible numbers about
okay, so thank you very much. I mean, I'm super impressed that that vision, you know, of crashing maternal, we use the word crash anyway, maternal mortality is, of course, becoming a reality. When I saw the Lagos State Dex officer, you know, talking about Mami, that is the state ownership. And so the entire, you know, Mami is going out of, she mentioned, the Nigerian Health Sector Renewal Investment Initiative, which is a reform to overhaul the health sector, and the fact that we are adopting the sector-wide approach, you know, which speaks about all of us, you know, from the federal, the state, and local government, community, having one plan, one budget, and then one report, as well as one conversation. So you've already heard what she said. So with that plan, clear blueprint, 4 pillars, you know, to say, let us improve governance, let us strengthen health system, let us ensure that there is health security. Yeah. But key there is improving the population outcome, health, which is the women, the children. So giving you that background, clearly, I keep telling everyone, it's no news, you know, that Nigeria contributes 30% of global maternal death, despite being, you know, 2% of the global population. What is new is what you are seeing. That concerted effort by the present administration, led by President Bola Ahmed Tinubu, launching Mami, you know, to say, you know what, moving forward, all of us, and like he said, if there is any position we must lose the position of contributing the highest number of maternal death. That's what the president said. Now, secondly, is that there's no sitting on the fence. All of us need to be, you know, on board, which inform the signing of the compact between the federal, the state, and then the entire local government, you know, to ensure that moving forward to reform our health sector, all of us need to be, hands to be on deck. And that's why we are here, you know, in Lagos State. We've been to 30 states now, you know, because we identify clearly Nigerian maternal mortality is contributed by 172 LGAs in 33 states of the Federation. And out of that, Lagos State is contributing one of the LGA, that's Ibejuleki. And that's why we are here. And clearly, when you look at asking where we're coming from, so the background is that our maternal mortality is high, you know, 512 as we speak now. But you flash back, you know, in 10 years, it has been oscillating. Yeah. Was in 2008, it was 545. And with all the huge investment, it jumped up to 576, you know. And then, of course, between 2013 and 2018, that's when it dropped to the 512. Now, what we're saying is that, and that's what she referred to, those silos approach, midwifery scheme, saving 1 million lives, all of those things will never work. If you look at, you know, the cost of drivers of maternal mortality, we have identified clearly, you know, the 5 delays. I haven't identified where the deaths are occurring in 172. We now look at why are they occurring. 5 delay of reaching, which you mentioned, delay in seeking health care, delay in then receiving health care. There's a problem with referring it to the next level of care. And then finally, that coordination is what is really missing. And that's why we are now, you know, seeing that moving forward to address all of this delay at a go, a woman needs to be registered, she needs to be tracked, she needs to be linked to the facility, she needs to have financial protection. There must be emergency transportation, and also we must ensure that the facilities that she's going is super ready. Either is a basic healthcare, basic emergency newborn care, which is primary health care, which is secondary health care. It must be super ready to provide that qualitative health care.
Just a quick one. What are the responsibilities, or rather, what are the objectives of this initiative? The reason I just want us to understand what it's about, and then because I see that you are trying to educate us already. I know the goal is to bring down the numbers, but what are the, maybe the basic targets? What are the objectives? What are the things that people will see and say, oh, okay, this is what this is all about?
So it's also saying that what are we doing differently? Okay. So that's why I'm trying, I gave you that background and say that, moving forward, there are clear things. Now, Mami's strategy, where first is to say the target is to reduce, she mentioned, maternal mortality by 30%. It's actually 2027, not 2030. 2027, in the next 2 years.
2 years, right.
We should be able to drop that figure. And, and then, of course, on the 5, newborn mortality, which again is super high. And, of course, increased facility utilization. Here is it. When you get the women to the facility, clearly, you are sure of that person that will take that delivery, that skilled attendant. So now, all the Mami strategic, framework, actually focuses, on getting the women to the facility and then ensuring that she has qualitative health care from a skilled birth attendant. One is to say community line listing by the community-based health workers. And so we are encouraged state to recruit community-based health workers, and the federal government, is also, trying to support some states, in doing this. Now, secondly, those community-based health workers will line list these women, link them to the next primary health care, and then, of course, from there, the tracking of this woman, starts, because particularly there's a triage at that primary health care to identify a woman that is high risk and then refer them to the next level of care. You don't allow those ones to go and, deliver in the primary health care. They have to go to the second level of care, which is the secondary care facility, the general hospitals. So that plan, that complication readiness, those are the features of Mami. Then secondly, to say this woman that is high risk or in distress is linked, to emergency transportation, which is the delay in reaching healthcare. And then, of course, in receiving healthcare, that's the third piece of Mami, is this facility component. So we have the access. The access, is to say physical access, she gets to the facility, financial access, financial protection for that woman. And that's why the president has declared, for every woman that is in need, she must have a free cesarean section, free of charge. Then third piece is the revitalization of the facility. That is the primary health care. See, as we speak, 2,000 has been done since this president's administration came up. Revitalization. There's additional 2,000 this year again to revitalize the primary health care. And there's ongoing revitalization of general hospitals or secondary health care across the country. This is one per LGA. And then there's a commodity that is going with it. There's equipment. You heard 3 weeks ago, coordinating minister that is leading in all of this, is ensuring the flag of the distribution. Out of the 172 AGA, 80 of the AGA, 500 facilities, they, definitely, got some commodities, what you call the MNCH commodities. They got it. Okay. And all of this. So in terms of intervention, we actually are looking at also strengthening that data, intelligence, surveillance, and then to report every maternal death, and then review it, and then be able to respond. And then create some enabling environment like the digital in health, and then, of course, the sector-wide coordination.
I would also very much I think you had a question.
Yeah, I was going to say that, everything seems perfect and good and looking beautiful. And, you've said so much. Some people, I'm enjoying what you're saying. I'm seeing the picture. I'm connecting everything. But, how real is this? you know, but the people that are expected to benefit. It's good to plan to put all these things into place. But how does it really, is it really working out the way it's supposed to work?
Perhaps that question is cascading it. Yes. How are we getting it to the people?
Yeah, how are we
because
getting it done?
It is one thing, you know, I said something earlier about the fact that initiatives are amazing, fantastic plans, but it's the challenge is usually in the implementation and sustainability.
Yes.
Okay.
Because at the end of the day, it's always the people.
Okay, thank you. So, like he was talking about the local governments. For example, in Lagos State, we have one local government, which is Ibejuleki. And so we've gone into Ibejuleki and we've gone to the women, not even the facilities alone. We have gone to interview some women. We did the verbal autopsies. Why do you think your child died? What happened? I know we got so many things. For example, I met a woman that she had we call it precious pregnancy, because the distance, the gap between her first and the current pregnancy is about 15 years. Okay. There's a PHC almost less than 5 minutes from her, a primary healthcare center. But she has registered at the general hospital, which is almost 45 minutes away from her. And I'm asking why. And she says, oh, because the pregnancy is precious. I'm like, no, at least register first at the PHCs. Then
Could it be because that the people don't trust the PHCs?
No, so she just feels because it's a precious pregnancy that the PHC is too basic for the pregnancy, so she would rather go to the... And I'm like, okay, I understand where you're coming from, but register first there and attend your regular ANCs so that at the very instance that some delay or some danger is noticed, then you can be transported to your journey. But if the PHC has no history of you, yes, it's going to be difficult. What if you fall into labor in the middle of the night? Do you understand? We also realized that they also had the problem of emergency transport, so ambulance services and everything. And so part of what he was talking about, the rural emergency ambulance service, it's going to be deployed first at Ibejuleki because of that factor. So, and most of those places are hard to reach. It's waterlogged. Even when we went there, and it was raining. Even to go through the road network was very difficult. So I know Lagos State of recent, we just launched we call them the Ambu bikes, you know. So those are the kind of things we would first deploy to those kind of areas so that I believe this time around it will work because we are more practical and it's context specific.
You know, there's something, you know, interesting in what my colleague said earlier. You know, that, look, these are the numbers. These are our realities. How we bring them down is another issue altogether. Just as Dr. Adeyanju said earlier, we all owe it to ourselves to ensure that this works, not just for the pregnant women, but for the children that they are going to give birth to, because some of them could probably have all the answers to
all our questions.
Cancer and all those other diseases that all of you have not been able to do anything about. Anyway, we have to thank you very much for your time this morning.
Yeah, so that's Dr. Dayo Adeyanju, the National Team Lead of the Maternal and Neonatal Mortality Reduction Innovation Initiative, MAMI. Thank you for coming. And Dr. Oyeyemi Ogunjobi, Swap Desk Officer, Lagos State Ministry of Health. A pleasure having you on the program.
Thank you for having me. Thank you so much.